Hi, good morning. Many thanks to Julio to organize this meeting. I'm going to present the residual inflammation and cardiovascular damage after CAP. In that room, I know that we are pretty aware about the importance of cardiovascular events and the long-term consequences of CAP. I will present our research in that field in our group in Hospital La Fe. The first, I'm going to see, no, to move here. The first part, I'm going to present our starting point and what we know and what has been published. And the first was a study performed in 4 hospitals, and we evaluated cardiovascular biomarkers during several days, day 1, day 4, and day 30, and the risk of presenting cardiovascular events early and late, after 30 days to 1 year later. So I'm not going to go deep into that because it has been published, but I want to select some ideas. First, that we have separated the patients, those without or with previous cardiovascular diseases, and the 3 times period where we have been evaluating cardiac biomarkers and inflammatory biomarkers. Of course, there is a slope before, during the first 4 days, and again, there was a decrease after the day 30. After adjusting for several other variables, we were able to find that there was increased risk factors in those patients with raised biomarkers at day 30, after adjusting for the other variables, sepsis, AIDS, chronic diseases, and so on. The second study, I'm going not to go very deep, is the study that we have performed and published in Thorax during the COVID pandemic, and we quantify biomarkers related with endothelial dysfunction, proadenomedulin and proendotelin. And what we found was first that higher levels in those with higher or more severe episodes, and there was a relation between the initial higher levels of these biomarkers and mortality. You can see the Kaplan-Meier curves here. And the other important question is that in those patients with raised biomarkers at day 30, there was consequences with impaired diffusion lung capacity. The next publication is concerning bronchiectasis and cardiovascular events. And this had been recently published, and with 2 important messages. First, those patients with cardiovascular events during an exacerbation have lower survival in the follow-up. And the second one, those patients with high levels of proadenomedulin have more cardiovascular events and, of course, more mortality. Now I'm going to show you, from now on, I'm going to show you non-published data, non-published publication, and what we are doing now. And the first is, of course, taking profit that we were in the COVID times. We have beginning a field of research in netosis, in NETs, the measure of NETs. We have been comparing the NETs in blood serum in patients with COVID versus patients with CAP. Also, we have been evaluating biomarkers, of course, but I will focus in NETs biomarkers. We have been measuring citrullinate histone H3 and cell-free DNA. And what we have been finding was that in patients, for example, histone, in patients with in-hospital mortality and cardiovascular events, there were higher levels in patients with CAP compared to COVID. But in both cases, levels were higher if the patients were suffering cardiovascular events or mortality. This is during the acute phase of the episode. I will show you more details later. No, we didn't find the same figures when we measure cell-free DNA. So our following studies concerning the residual cardiovascular inflammation and damage, as you can see, we have been performing only biomarkers. You can see in the figure that there are another methods to evaluate inflammation in cardiovascular in the vessel, but of course it's not feasible for us. Biomarkers have several advantages. We decided to continue this kind of investigation that is more feasible for us. So the first study is almost finished, but it has not been published yet. It's almost finished. And we were quantifying the residual cardiovascular and inflammation after 30 days, but we were trying to find the risk factors associated with that residual damage, considering several parts: the patients, the microorganisms, the initial severity, and the initial damage with biomarkers. So this is the flow chart. We consider that there was a residual cardiovascular damage of inflammation at day 30, using as threshold the upper laboratory normal limits of the biomarkers. You can see here all the patients that we have and all having a late cardiovascular events. And the main results are, you can see, are here. We have separated information. Here you have the percentage of patients with cardiovascular raise at 30 days, the percentage, and we separate those with previous cardiovascular disease and those without previous cardiovascular disease. And in each part, we have separated those suffering an early cardiovascular event in orange and those without suffering an early cardiovascular events, because it's logic that if you have an early cardiovascular events, you will have rise your cardiac biomarkers. So the first conclusion or the first message is that in patients with previous cardiovascular disease, they have raised cardiac biomarkers compared with those without previous cardiovascular disease. And the second idea is that in those suffering an early cardiovascular events, they have higher levels in both cases. But for me, it's also important that patients without previous cardiovascular disease and without early cardiovascular events, we have a residual cardiovascular damage, we can say that, because at least 20 or 30% or even more than 50% have raised levels of cardiac biomarkers. And this is intriguing and interesting. And when we combine all the factors in a multivariate analysis, because we were interested in joining all the variables together, all the independent variables related with raised levels at day 30.
Not on statins or history of MIs.
Statins and antiplatelets have been studied.
Right.
And they were not statistical significance
in the
multivariate analysis.
I see.
No, because we were interested specifically in patients treated with prior treatment, of course, the chronic treatment with statins and antiplatelets, and it is not significant. When we introduce the initial levels and other risk factors, no significance.
So that means that,
for example, cholesterol specifically, we have not used an independent variable. We have used hypertension, diabetes, cardiac disease, but not cholesterol.
I see. Thanks.
Smoking, but no cholesterol.
Thank you for your beautiful presentation. I'm really impressed by your work. I have two questions. First, when you show the mortality data and you see that if you have a high pro-ADM, for example, mortality is higher, I'm wondering whether this is truly because of cardiovascular events, because if you are in an ARDS community, pro-ADM is a measure for endothelial barrier dysfunction. And so I would assume that those who have a high pro-ADM may also be the patients who are more severely sick than others, for example. And the second question, if I may, what is downstream of these biomarkers? I mean, it's obviously ongoing inflammation in the vascular system, but does this increase the size of atherosclerotic plaques, or does it destabilize the plaques? Or what is exactly, or what do you suppose is going on?
Concerning pradenomedullin, of course, we like a lot this kind of biomarker because it's very helpful in many aspects. The idea that we have that is showing endothelial dysfunction. So it is related with cardiovascular events, but in some cases we found rise pradenomedullin without evident any cardiovascular events because probably it's mirroring the endothelial dysfunction, is not making a specific arrhythmia or so on. But the problem is there. The problem is there. So that's why we are finding this kind of results severity, because if there is endothelial dysfunction in an pneumonia, in COVID or no COVID, because it was in both of them, you are going to have a more severe episodes, probably a problem, because I don't know how to identify another biological identification of the problem. In one of my slides, I presented the graph of how to measure vascular inflammation, because I find it is very interesting. I am not able to do that and to compare with biomarkers, but I think this is a way to do it and to see specifically the problem in the endothelium. So this is nice, but I cannot do that. And the second question was about?
What's downstream? Atherosclerotic plaque disruption or increase of size? Or...
Yes, the problem with cardiovascular events, I think that is multifactorial. One, probably, altered inflammation, destabilization of the atheroma plaque, inflammation, probably netosis is also combination because it provokes immune thrombosis and microthrombi. So altogether, I don't know how is the strength or which percentage is one part or other, but because we are seeing something like a biomarker, but probably it's mirroring all these kind of physiological components.
Yeah, thanks for that great talk. I had sort of a similar sort of thought, comment, I guess, a couple questions. I was just thinking about the types of cardiovascular events, like the work you're presenting here had the cardiac biomarkers, but the clinical events, they're very heterogeneous and sort of combining MIs and arrhythmias and even heart failure. And so that some of that heterogeneity may be in fact sort of that there's different pathogenic processes leading to these events. But in clinical studies, the events may be so more rare and that combining them gives us more power. And just thinking about how can we, maybe we need combined cohorts to be able to study each of these events individually to gain more insights into some of that, some of the heterogeneity into the mechanisms. I'm kind of wondering your thoughts on that. And then
of course, this is a very important aspect because, as you have said, we have arrhythmia, heart failure, and several others cardiovascular events. Yeah. The curious of the story is that even some biomarkers are more specific of any damage. When something happens, all of them rise. It's curious because we have been checking that in order to be more specific. Of course, probably if we have a very large cohort with thousands and thousands of patients, probably we will be more specific for this kind of question that you are doing. But in our study, we have been trying to do something like that. For example, is protein pain higher in those with heart failure? Is troponin increased, of course, if there is ischemic event? You can see that, but in general, all biomarkers rise. One more and other less, but this is it is.
Yeah, and my other question was kind of thinking about the sort of severity of CAP and also how treatments like steroids might impact the biomarkers that you're seeing.
Yes, very interesting. There is a publication by Kangemi answering that question specifically. And they said that in those patients with cardiovascular events and more inflammation, they were able to show that there was a reduction of cardiovascular events. So it has been published like that. And I am interested because my idea is that we probably will be able to identify this kind of target of patients to do something. For example, in netosis, there are publications with ticagrelor in order to reduce netosis and to reduce damage, organ damage with ticagrelor. And some statins also.
Yes, this is a good question.
Thank you. I was wondering how many of these patients were hypoxemic, the patients with heart that you studied, and did you see any association between the extent of hypoxemia and the severity of hypoxemia? And furthermore, how many of them were intubated? For what period of time? Because we know obviously that mechanical ventilation or positive pressure ventilation is a risk factor, especially for right heart dysfunction, right? So were they able to make any discrimination?
Very, very nice question too. First, in our cohort, the proportion of patients intubated is very, very low because most of them, 94% are for the floor. So very few are coming from the intensive care unit because our cohort were more moderate pneumonia, hospitalized, but moderate pneumonia, and no the group of intensive care. So the first question. The second, concerning to hypoxemia, this was very important for one part, because after we found that one of the most important independent variables for rise levels of biomarkers day 30 was initial levels, immediately we perform a multivariate analysis to evaluate where were the variables involved in the rise initial levels. So, because it was important. And the independent variables were, of course, severity and hypoxemia, not the duration. I didn't check on that, but the hypoxemia and the severity, initial severity, and Streptococcus pneumonia and mixed infections were independent variables for rise initial levels.
Yes, so yes.
What is the role of the affection of the coagulation cascade? Because one of the main complications of inflammation and infection on the heart is atrial fibrillation. And if there's more atrial fibrillation, it's very likely that there are more stroke events, and this has nothing to do with arteriosclerosis. So it's another part which is very hard to study, but which may also show long-term consequences, because the arrhythmia will stay, and passager atrial fibrillation is a main risk factor for several of the diseases.
Yes, I agree, but it's very difficult to identify the microthrombi in the organ damage. That's why we are trying to investigate netosis, because netosis and P-selectin is also related with more platelet activation and more probability of microthrombi. And we are finding higher levels of netosis and peak selecting initially in pneumonia, but I cannot give you the information of microthrombi in around because it's not.
So excellent talk on a critically important thing. You know, if this is a research conference, the idea is we think too small. The risk factor for the latest anti-cholesterol drug, they had thousands and thousands of patients for an infinitesimal change in their mortality, you know, a combination endpoint. You know, an episode of community-acquired pneumonia is now the greatest risk factor for getting cardiovascular disease in most Western countries, and we're ignoring it. And we're not doing the kind of big interventional studies that cardiology has been doing for a long time for, you know, just one little bit of change in mortality. And you know, you look at our 30-day mortality for CAP, you look at the long-term mortality for CAP, we're wasting a lot of time, you know, trying to convince the wrong people that this is a risk factor. We should be doing large multi-center trials of some intervention, whatever, you know, it is, because it's clearly a risk factor.
You're totally right. We need to convince cardiologists and primary care.
But the NIH, we have been there multiple times. I said, this is the research that needs to happen, but the funding is not coming.
Can give you an important implication. I was in touch even with the American Cardiac Society and the European, and asked, why is there no vaccination recommendation in your guidelines?
But there is in the European.
Yeah, there's not. So it's totally ignored. And this is something, yeah, this is preventive, not only for pulmonary disease, but also for cardiovascular. Yeah.
Very good point.
Then, yes, go ahead.
So maybe to briefly comment on Tobias, there was this JAMA study, I think in 21, showing that if you have a myocardial infarction and get influenza vaccination, you are at a lower risk for a secondary myocardial infarction. And that's why the European guidelines now recommend that patients with a first myocardial infarction get influenza, only influenza vaccination. But I wanted to ask Rich, I fully agree. But the question is, what would be the intervention?
So we need to look at the traditional ones. So we need to look at cholesterol and be sophisticated about it. I mean, you know, frankly, we're, at least an intensivist like myself, we're part of the problem because we kind of dismiss these elevated troponins and say it's just stress and all this kind of stuff. You know, if you had that troponin and that CRP and you were admitted to the CCU, you would be trying to decide whether you're going to the cath lab or not, and everybody would get an or get a statin and probably dual antiplatelet therapy while you're waiting to decide on that. So, you know, we're part of the problem because we're accepting them saying, oh, that's just stress-induced ischemia and not cardiovascular disease, when, yeah, some of it's stress, but there's a whole lot of coronary disease that's hidden under our CAP admissions.
So, I mean, there's pretty good retrospective data on aspirin that this might be protective in post-pneumonia.
Right.
And then there's even a very small Turkish trial showing, a prospective trial showing that the risk is reduced when you give aspirin after pneumonia. But the question would be, would you go for a dual antiplatelet?
So the cardiologists have sorted this all out, but we just need to apply what they've learned with acute statins and antiplatelets in, you know, I mean, it seems a shame that we have to do this, to do a randomized controlled trial of what should be state-of-the-art preventive therapy for coronary disease. And
so wait for my presentation this afternoon.
okay.
It's hard to design these trials because, as Rosie showed, most of the patients are elderly and they are on cardiovascular drugs, to find someone suffering from pneumonia but not treated is.
I would disagree. There's many, many, many,
Yeah.
many that are not treated or undertreated, that come in with community-acquired pneumonia. At least in our institution, we have very aggressive primary care and cardiologists, but there's many out there that are not getting state-of-the-art preventive therapies for.
Okay, so
coronary
we
disease.
should start a study, yeah?
Yeah.
Then going back, this is another comment. Then you mentioned that there are patients that don't have cardiovascular history. And these patients without cardiovascular history, they are going to, these patients develop increased biomarkers and then develop cardiovascular disease. Then these increased biomarkers initially is a reflection just of the inflammation of pneumonia and damage in the arterial cell, or these increased biomarkers are already telling us that the pneumonia is already causing heart damage?
We have several ideas or hypotheses for that. Maybe the patient has an unknown initial cardiovascular disease, unknown, and the pneumonia is capable to trigger the mechanism. Or this is a possible answer for that, because we are not sure about that. Probably the patient has something, but in a very mild or initial phase, and he was unaware of that. And pneumonia is capable to trigger that. This is probably.
Yeah, this is probably the most likely explanation. We have a lot of patients with subclinical cardiovascular disease that the pneumonia make it clinical.
Yes.
Yes. Any other research in the area of identifying I mean, I understand that the treatment is the answer, but at the level of understanding of this, any other consideration based on what? Then going back to your netosis, then you think that the netosis is the acute process, you have netosis, and then this favors the inflammation, and then you don't see a correlation netosis 2, 3 weeks, 4 weeks down the road, but it's the acute netosis that caused the problem.
Yes, yes. At least it was we are founding. This is not a complete study. This is an ongoing study, but we have quite enough data. And what it is interesting is that the problem is the acute netosis, but netosis decreases, of course, at day 30. This is logical because netosis are produced by neutrophils, and this is a more innate immune response during an early phase and not so late.
Yes. Very good. Any other comments for Rosario? Then I understand that this is perfect. We are on time. We are going to break for a coffee and we restart 10:30.